PAKAR services. I'm Dayu, your moderator for today's occasions. It is an honor for me to introduce and also welcome the Honorable Guest Lecturer, Dr. Elizabeth Kathleen Darling. Okay, please give a big applause. Thank you, Dr. Elizabeth. And distinguished head of Central Indonesian Midwifery Education Association, IPKIN, Dr. Randa Yumiarni Ilyas MKes. Please give a big applause. To distinguished Rector of Institute of Technology and Health Bali, Dr. Putu Dharma Suyasa. To the head of IPKIN Bali Province, Dr. Gusti Ayu Marta Winingsih. Welcome to ITEKES Bali. To the head of Bachelor Program in Midwifery Institute of Technology and Health Bali, Mrs. Duina. And please give a big applause to all participants in this convention hall. Ladies and gentlemen, in today's guest lecture, we also have participants that join us in the Zoom meeting. So as you can see in the slide, there are some of participants that already joined in the Zoom. So we have our clinical instructor from our partner institutions. As well, we have students and also lecturer of midwifery from all institutions in Bali. So I would like to deliver my greetings to all the participants in the Zoom. Welcome to the guest lecture for today's sessions. And I'm really happy to see all of you in our convention hall of ITEKES Bali. Ladies and gentlemen, this guest lecture is hosted by Bachelor of Midwifery Institute of Technology and Health Bali in collaboration with Indonesian Midwifery Education Association, IPKIN. And this event is over student the opportunity to meet passionate, committed, and critical people to learn from the expert in various ways. And in today's sessions, we already have our honorable guest, which is Dr. Elizabeth Kathleen. Thank you so much for your time and also the time that you already given to us to share your valuable experience to our students. Thank you so much. And also, I would like to proceed to our next agenda, which is our next agenda is having prayer. So for ladies and gentlemen, please arise. Please pray accordance with your own religion and belief. Ladies and gentlemen, prayer begins. Ladies and gentlemen, pray finish. Ladies and gentlemen, please be seated. Ladies and gentlemen, now I would like to invite the Rector of ITEKES Bali, Mr. Putu Dharma Suyasa, to come up to the stage to deliver the opening remarks and open the event officially.
So, thank you, Ibu Dayu. Ibu Dayu is the most beautiful girl in this room. She is still a girl. And I am the most handsome man in this room. So, thank you very much. Distinguished speaker, Dr. Elizabeth Darling from McMaster University. Ibu kita, our mother. Ibu, saya panggil Ibu Iyum aja ya, panggilan akrab beliau. Ibu Yum, Ibu Disa, ya, Bu Marta, Bu Dwina, all lecturers who are coming to ITEKES Bali and also in the Zoom. They are still there, but it's not on the screen. And students of ITEKES Bali and students from all midwives or midwifery institutions here in Bali, and all our colleagues, all clinical instructors, all practitioners, and everybody who are joining our sessions today. Dr. Darling, on behalf of ITEKES Bali, once again, we welcome you to our university, ITEKES Bali, especially to our midwife sharing sessions today. We do believe that we need to discuss more. We need to learn more. We need to adapt more. So we do also believe, especially after the COVID, we become persons and we become organization that value adaptations. If we cannot adapt what change in this world, I believe we will be left behind. So to start it all, discussion, sharing session is essential. So through this session, we will hear from two distinguished speakers. One is here today, and maybe another will be coming later, joining our discussion and sharing session later. So again, on behalf of ITEKES Bali, Dr. Darling, thank you for this sharing session. Ibu Yum, Mbak Disa, thank you for the opportunity given to us to know Dr. Darling in person and to host this very important session. And for our colleagues from all institute, from all STIKES, Poltek, dan Poltekes, dan universitas. So, bagi yang baru pertama kali di ITEKES Bali, selamat datang di ITEKES Bali. Bagi yang sudah pernah, welcome back to ITEKES Bali. I hope this will be very beneficial for our education and also for midwives practice for the people. Thank you very much, and we do hope that you enjoy the session. Thank you.
Thank you, Mr. Putudharma, for the opening remark as well as opening our event today. And now I would like to proceed to our next agenda. So, ladies and gentlemen, I would like to invite the head of Central Indonesian Midwifery Education Association, or IPKIN, to deliver the speech. To Dr. Randa Yumiarni Ilyas MKes, please come up to the stage.
Kalau Pak Rektor tinggi ya, ini diturunin dulu sedikit. Terima kasih atas waktu yang diberikan. Saya sangat senang pagi ini. Ini adalah kelompok pendidikan kesehatan yang ada di Bali ini, dan kebetulan ini diterima oleh Pak Rektor dan seluruh jajarannya di ITEKES Bali ini. Tentu saja IPKIN sangat-sangat berterima kasih karena acara ini, acara yang boleh dikatakan dibuat sedemikian rupa dalam waktu yang singkat dan beliau sangat bersedia membantu. Kenapa? Kami ingin berbagi sebetulnya dengan adik-adik dan juga para dosen dan preseptor untuk memanfaatkan kedatangan dan kehadiran banyak konsultan kebidanan yang kebetulan berkumpul di Bali. Sebetulnya kami ingin membawa lebih banyak, tapi apa boleh buat ya, karena waktu mereka juga sudah banyak yang pulang. Tapi ada beberapa yang masih ada tinggal dan nanti siang akan dilanjutkan lagi oleh satu orang lagi, Ibu Andrea. Kalau pagi ini beliau dari Ibu Elizabeth ini dari Kanada, dari McMaster University. Dan barangkali kita bisa dapat info sedikit-sedikit, siapa tahu nanti ada yang mau sekolah ke sana. Khususnya untuk dosen-dosen ya. Terbuka peluang yang banyak sekali sekarang dengan adanya LPDP dan juga beasiswa dari Dikti untuk bisa dimanfaatkan sebanyak mungkin. Kemudian Ibu Andrea nanti beliau dari Auckland University, mudah-mudahan juga nanti banyak informasi yang didapat. Bali dengan New Zealand kan paling dekat ya, cuma 6 jam penerbangan. Jadi tidak usah takut-takut kalau mau sekolah ke sana, meninggalkan keluarga, bahkan bawa saja keluarganya ke sana. Sudah ada beberapa dosen yang ambil S3 di sana, membawa keluarga dan akhirnya anak-anaknya di sana jadi pintar bahasa Inggris. Jadi tidak seperti eyangnya ya. Jadi di sana itu anak-anaknya juga sekolah, sekolah dan gratis sekolahnya ya, tidak kayak di Indonesia. Pagi ini saya baca Pak, anak TK mau wisuda, orang tuanya itu sangat tidak mampu sehingga akhirnya menggadaikan sawahnya untuk ikut wisuda. Nah ini juga adalah suatu perhatian bagi kita yang tidak perlu-perlu, barangkali bisa dikurangin begitu. ITEKES sebetulnya sudah banyak kegiatan ya adik-adik dan ibu dosen. Barangkali untuk ke Bali cukup banyak ya informasi yang sampai, tetapi ada hal lain yang baru ini juga kita galakkan. Kami juga kemarin ada rapat Pak Rektor untuk ujian kompetensi. Ini masih berlaku, kan kemarin agak sedikit ada peninjauan-peninjauan dan ada pembentukan pengurus baru juga yang nampaknya akan segera bekerja. Nah mudah-mudahan kesempatan uji kompetensi ini juga dimanfaatkan yang sebaik-baiknya. Tryout juga tetap kami lakukan. Mudah-mudahan adik-adik juga nanti mencoba ya berlatih dan juga dosen berlatih membuat soal yang lebih baik sehingga tidak banyak soal yang terbuang. Saya kira itu beberapa hal yang pada pagi ini saya tidak panjang lebar. Kita ingin banyak mendengarkan dari Ibu Elizabeth ini apa ceritanya tentang perkembangan ilmu kebidanan ya, midwifery, science and arts di makeover ya, McMaster. Terima kasih. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Anda Yumiarni, for this speech. And now I would like to invite Dr. Elizabeth, Dr. Putu Dharma Suyasa, Dr. Gusti Ayu Marta, Mrs. Dwina, and Mrs. Disa to come up to the stage to have group photograph. Yes. Thank you very much for Mr. Putu and all distinguished guests. Okay, to all distinguished guests, you may return to your seat.
Supaya waktunya efisien.
Oh, you may sit.
Do you want to?
Just you sit. Kasih ya semuanya langsung aja.
Okay, so ladies and gentlemen, now we are comes to our main agenda. So in our main agenda is the presentation from the guest lecturer. So in today's sessions, we have actually two guest lecturers that will bring an interesting topic that related to the continuity of care in midwifery care services. In the first sessions, we already have Dr. Elizabeth Kathleen Darling here to present the valuable information and also valuable experience to all of our students and also audience here. Before we start this presentation, I would like to give how these presentations will be going on. So for each speaker, you will be given time 2 hours to deliver the topic as well as discussion sessions. So please take your times. And also for the audience who want to deliver the questions, you may raise your hand. And if it is you cannot speak English, for example, you can use Bahasa Indonesia and I will help you to translate it. And for all of the audience in Zoom meeting, if you have any question, please type the question in the chat box and I will read it to our speaker. Okay, ladies and gentlemen, our first speaker is Dr. Elizabeth Kathleen Darling. She is Associate Professor at Department of Obstetric and Gynecology, McMaster University. She is also a co-founder of McMaster Midwifery Research Center, and her research focus on maternal newborn health services with area of interest include midwifery services, health disparities, access to care, health policy, and perinatal health surveillance. In today's sessions, Dr. Elizabeth will deliver a topic about continuity of care in midwifery care services. Well, without further ado, please welcome Dr. Elizabeth Kathleen Darling. For Dr. Elizabeth, time is yours.
Thank you so much for the invitation to be here. It's a real privilege for me to be in Indonesia, and I've already had the opportunity to learn a lot about how midwifery works in Indonesia, and I'm so impressed to be in a country where there are so many midwives. You have so many strengths as midwives in Indonesia, and I'm really looking forward to today being an opportunity for us to share, and I'm going to talk to you about our experiences in Canada, but I'm also very interested to hear about your experiences. And I think one of the things that's so wonderful when we have the opportunity to exchange across different countries is that there often are many differences, but we also have similarities, and we can learn from each other and take ideas and adapt them and change them. So please, anything that I share with you today is about our experience, but you're welcome to share your experiences and also to take these ideas and make them work for you. So I wanted to thank IPKind for initiating the opportunity to be here today, and also to ITEKES University for hosting me. It's very nice to have the opportunity to visit your beautiful university and to learn more about all the work that you're doing here. Yes. Okay. Okay, thank you. So I just wanted to give a bit of an overview about what I will speak about today. I'm going to be talking about continuity of care, and I recognize we have a range of people in the audience. So for some of you, you might be very familiar with the concepts of continuity of care. And I also know we have some students in the audience, and maybe some of these ideas are a little bit newer to you. And so I just wanted to go through so that we all have an understanding of what we mean when we talk about continuity of care. And then I wanted to just also talk about what are some of the benefits of continuity of care for midwifery. And I'll talk about how this impacts the experiences of our patients, of the women and the people that we care for, how it impacts the quality of care, and also how it impacts our experience as midwives when we're working as midwives. And then I'll talk a little bit about different models of continuity of care, because there isn't only one way to do continuity of care. There are lots of different ways that people organize how they work in order to provide continuity of care. And I'll share with you some of our experiences in Canada and how continuity of care looks there. And really, again, I say those are for inspiration, and it may be that the way that continuity of care evolves in Indonesia looks different, because you will make it work for your individual context and where you're working. I want to talk briefly about some of the challenges around continuity of care and some of the potential solutions. And then I thought I would maybe just share a little bit at the end about some of the things that we know from implementation science about how we might implement new innovations in healthcare. And I'll talk to you about an experience that we had in Canada, not with continuity of care, but with implementing it alongside midwifery unit, and just briefly share some of the lessons that we learned from that are things that might be helpful to think about as you try to implement continuity of care in different contexts. So continuity of care has been defined in a number of ways, but this is, it's also used fairly broadly in healthcare. So midwifery isn't the only area in healthcare where we talk about continuity of care, and there's been quite a lot of research done on this topic, even beyond midwifery. I wanted to share this definition from the Royal College of General Practitioners in the UK, because I think it's a nice broad definition of what continuity is. So they define continuity as the extent to which a person experiences an ongoing relationship with a clinical team or a member of a clinical team, and the coordinated clinical care that progresses smoothly as the patient moves between different parts of the health system or the health service. One of the other things that I think is really important to understand when we talk about continuity is that we often think about 3 different components to continuity. And when midwives offer continuity of care, we provide all 3 of these things. But in some cases, care might be organized in ways where you only have 1 or 2 of these things and not all of them. But the goal with midwifery-led continuity of care is to provide all 3. So the first kind of continuity that we talk about is informational continuity. And this has been defined as the use of information on past events and on personal circumstances to make care appropriate for each individual. And so this really is one of the ways in which we are able to offer personalized care as midwives. And one of the important things to understand about how continuity of care works is that often information about some of these things, like about the personal circumstances of the person we're caring for, are things that just exist in our heads. We remember them because when we meet with people, we hear their stories, we ask them about how their lives are going, and as midwives, there are details that we remember that never get written down in their medical record, but can be important for us to be able to provide good care. The second kind of continuity that we talk about is management continuity, and this refers to the way in which care is being provided. Management continuity is a consistent and coherent approach to the management of a health condition that's responsive to the patient's changing needs. So, as you know, we always adapt what we're doing in response to what is happening in the care as it unfolds. But with management continuity, if we have a team of midwives, it means that if the woman who's pregnant sees any of them, the information that she'll be provided will be similar, and they will recommend things in the same way. So she won't hear one thing from one person and something different from another care provider in her team. People work in the same way and have a shared approach to how they're providing the care. The third kind of continuity is relational continuity, and this refers to an ongoing therapeutic relationship that occurs between the patient and one or more care providers who are providing the continuity of care. And we think that probably in terms of the benefits of continuity of care for people who receive midwifery continuity of care, this might be maybe the most important piece. The relationship that we develop with the people that we care for is a basis for many of the benefits that come from continuity of care. And I'll talk a little bit more about this in some of the upcoming slides. Within the profession of midwifery, we've been talking about continuity of care for quite a long time, since probably maybe even the 1970s, at least the 1980s. In our research and in the way that midwives are working, we have talked about this idea of continuity and establishing an ongoing relationship between one midwife or a small group of midwives and the people that we care for. Our understanding of continuity and of the benefits of continuity has evolved over time. So when I looked back at some of the research that had been done, there was a large review of the evidence about continuity of care that was conducted a long time ago now, in 2000, so 23 years ago. And at that time, they defined continuity as having fewer caregivers, either overall or during pregnancy, or as having a known care provider in labor. And these definitions are still used as the basis for what we think of as continuity in midwifery care. One of the interesting things, though, is that when we look at this early research, they suggested that maybe there weren't benefits in terms of satisfaction with continuity. But we know, as we've gathered more evidence over time, that having continuity of care is an important factor in supporting increased satisfaction for people who give birth. So I'll move on to a more up-to-date definition. This definition comes from the Cochrane Review by Jane Sandel and her team, which looked at the evidence around how midwifery-led continuity of care impacts outcomes. And they defined midwifery-led continuity models as those models in which they provide women with care from the same midwife or a team of midwives during the pregnancy, birth, and early parenting period, so across all of that time period, with referral to obstetric specialist care as needed. And the continuity of care involves care coordination, the provision of care, and building a relationship over time. And I had the privilege of being at the ICM this week, where Dr. Jane Sandel was just presenting about her research, and she couldn't share the results yet, but they have just updated the Cochrane Review, so hopefully it will be published within the next year. And they may make some slight changes to this definition, but essentially this definition remains the same. One of the things that they have specified in the new Cochrane Review is that we used to think about midwifery-led continuity of care as maybe being restricted only to people who have totally normal births, so only where everything remains within the scope of the midwife. And the thinking has evolved over time that we can still also provide continuity even when people develop complications. We can set up systems so that the pregnant woman is still supported by her team, by a small team, even if she needs specialist care as well. So there's a little bit more evidence that has been compiled in the last few years that will be incorporated into the upcoming Cochrane review about that. So just to talk a little bit more about the systematic review, we know that when we're looking at trying to provide evidence-based care, we want to have evidence from randomized control trials whenever that is possible. And the best kind of evidence that we can have is actually a synthesis of all of the randomized control trials, so we can pull on all of the high quality research that's been done. And the current version that's been published was, for this Cochrane review, was published in 2016. So it's almost 7 years old now. And like I said, there hopefully will be a new publication coming out this year. But the 2016 Cochrane review included 15 randomized controlled trials. And altogether, there were 17,674 women who were enrolled in those trials. So those are all the people that we have evidence from randomized control trials to tell us about what are the outcomes when we provide midwifery-led continuity of care. The approach that was used to conduct this systematic review was of high quality. So they followed the appropriate procedures to do a systematic review. They used the grade approach to assess the quality of the evidence. And the evidence that we have is generally very high quality. So the randomized controlled trials that have been done to study midwifery-led continuity of care are high quality and have been evaluated to be high quality. So there's a lot of information on this slide. This is from the 2016 results, and I'll just briefly go over some of the clinical outcomes that they looked at. So the evidence from the systematic review shows that we see a reduction in interventions overall when we have midwifery-led continuity of care. And two of the specific interventions that they looked at were regional analgesia and instrumental vaginal birth. And so with both of these, we see a reduction. There's less intervention when we have midwifery-led continuity of care. So for regional analgesia, the risk is reduced by 15%. If you have midwifery-led continuity of care, you're less likely to use regional analgesia during the labor. And there's also a reduction by about 10% in the rate of instrumental vaginal birth. So less likely to have instrumental vaginal birth. The other very important outcomes that were reduced are some of the negative impacts that we want to try and prevent. And this included fetal loss before 24 weeks and neonatal death, and also preterm birth. So both of those are reduced. The rate of preterm birth is reduced by almost 24% when we have midwifery-led continuity of care, and that's a very, very important outcome. We know that most of the morbidity and mortality for births, it comes from preterm babies, and so if we can prevent preterm birth, we can help more babies to survive and be healthy. These outcomes will also be updated in the upcoming Cochrane review. We saw some increases in beneficial outcomes, so a higher rate of spontaneous vaginal births, so about 5% increase in the rate of spontaneous vaginal birth when there's midwifery-led continuity of care, and no differences were found in the previous review in terms of the rates of cesarean section and intact perineum. I now want to talk about breaking down some of the outcomes as well into a little bit more detail. So one of the other very important things that we think about when we're looking at how do we deliver healthcare is what is the experience of the patient, or how for the pregnant person, how do they experience midwifery-led continuity of care? And the majority of the studies, they measured things in very different ways, but they all found that, or they mostly found that there are higher rates of maternal satisfaction when we have midwifery-led continuity of care models. So it creates a better experience for the person who is giving birth. And I'll talk a little bit more over the next few slides also about how does this work? Why are people more satisfied when they have continuity of care? And so, and also how does it support normal birth? And I think when we look at the benefits of the patient experience, when we have continuity of care, it allows us to develop a relationship with the person who's giving birth and get to know them. We start to understand what's important for them, and that helps us when they're actually giving birth, for us to give them care that's going to make them feel satisfied, because we know what's important to them. We can support their choices. We can help to facilitate them to have a birth experience that's as close to possible as what they would like to have happen. The other thing that I think is also important is that when we develop that relationship, it allows people to establish a relationship of trust with their midwife. And we know that there's an association between our feelings of trust and comfort and ease and what's happening physically in our body. And when a woman has a lot of stress and doesn't feel like she can trust anyone, it increases the cortisol levels in her body. And so physically, that increase in the cortisol levels can disrupt the progress of her labor. It can make it more difficult for her to have a normal labor. And so if we can help people to feel comfortable and safe, then we can help to support physically what's happening in her body with the labor, and that helps to support normal labor and normal birth. We also know, and looking at all those clinical outcomes that I talked about, that continuity of care is helping us to provide better quality care. We're preventing negative outcomes that we don't want. We're not using interventions more than we need to and creating harm. And so how does that work, and why does it support normal? Well, some of the things that we think might be going on here are that if we have continuity of care and somebody who knows the woman in labor is with them when they give birth, then it's less likely for us to overlook important information. So we can try and make sure we have all the information that we need in their documents or in their pink book, but it's also important sometimes the information that we have in our heads about who this person is and what's important to them. So when we provide continuity of care, we make sure that we have somebody who knows that person, and we know about the things that are important to them, but we also know about the things that are important in terms of their health. Are there things in their medical history that we need to know? Are there things that are important about their last birth that tell us about maybe things that might be more likely to be a problem in this birth? And having all that information at the top of our heads makes us better able to provide care that really is appropriate and safe. The next thing is that when midwives are responsible for looking after someone and see themselves as the primary care provider, they take the responsibility to make sure that the care is well coordinated. And so having midwifery continuity of care, if you're seeing somebody every time they come in for their visits, or you and your team of midwives are seeing them, then you will notice if there are things that should have happened that aren't happening. And as midwives, we take responsibility. We act like a bit of a safety net. So if somebody should have had a test done and they didn't have that test done, or they had a test done and nobody's looked at the result yet, midwives take responsibility to make sure that those things can get done. And when we provide continuity of care, we have a focused group of patients that we're looking after, and we coordinate that care in a more effective way than if there are 20, 25 different people who all might see that person and nobody really feels like they are responsible to make sure that she gets the best care possible. The other thing that we think probably contributes to improving the quality of care when we offer continuity of care is that we have more opportunities to prevent complications and to diagnose complications early. And it allows us to work to provide holistic and comprehensive care that's very personalized. And so some of these things that we can do early in the pregnancy help us to prevent things like preterm labor. So finally, I want to also talk about how does this impact us as midwives when we provide continuity of care. We actually have quite a bit of research that shows that providing continuity of care is associated with satisfaction for midwives. Midwives really like to provide care in this way. And there's a number of reasons why. When we provide care in a true midwife-led continuity of care model, it supports us as midwives to have more autonomy and to be able to use all of our skills and all of our expertise in a more effective way. And so that's one of the things that's very important about continuity of care, is that it allows us to use all the strengths of midwifery and to really make the biggest impact. And it also enables us to make sure that we're using best practices that are what we understand from our expertise as as midwives to be best practice. Sometimes if we work in systems where, as a midwife, we're just following the direction from an obstetrician, we aren't able to bring our knowledge and our what we know are the things that we can do to support normal and uncomplicated birth to the care that's provided. And when we support midwives to be able to lead the care and be able to develop a relationship with the people that they're caring for, then we are truly able to support their choices and to support choices that help to support normal and uncomplicated and healthy births. So I'm going to talk now just briefly about some models of care. When we look around the world, these are three of the countries that we sometimes think about in terms of continuity of care models in midwifery. So the Netherlands is probably one of the places where they've had a long-standing establishment of working in midwife-led continuity of care models. In the Netherlands, when somebody is pregnant, they will all go to see a midwife, and those midwives work in private practice in the community. And everybody who doesn't have complications has primary care from a midwife. And they usually are organized in small teams, either by them, they might work on their own, or they might work with a small group of midwives, so they get to know the people that they're looking after and provide continuity. New Zealand is another country where most people get continuity of care from a midwife. So they have a system in New Zealand that's called the lead maternity carer, and every person has a named lead maternity carer. Most people choose a midwife. If somebody has complications, they might need to see an obstetrician. And some people pay for private care from an obstetrician, but most people choose midwifery, even if they if they're able to. And again, midwives in New Zealand are based in the community. They provide care in the community. They can provide care for births at home or in birth centers, and they can also provide care in the hospital if people choose to give birth in the hospital. Another place where we've had a lot of research about continuity of care is in the UK. And the standard system in the UK has not always involved continuity of care. Midwives in the UK often work in hospital-based units, and they may work just in antenatal care or just in the birthing ward, or they might work just providing postnatal care. But they have over time been starting to change that model, and in the 1990s they had a big report called Changing Childbirth, and one of the things that they identified as being very important there was to try to implement continuity of care. And so they have moved over time to try to implement continuity of care in all those different settings. So they have continuity of care model teams that are based in hospitals. They also have continuity of care teams that are based in the community. So a range of different settings. And now I'm going to talk a little bit about Canada, where I'm from. So this is a map of Canada. And in Canada, midwives are autonomous professionals. And we work, almost all of us work in midwifery-led continuity of care models. Just a very small number don't. That's really been the main model of care in Canada. And we're all the primary care provider at the clients that we look after during pregnancy. Continuity of care has been identified by the National Midwifery Association and by the National Council of Midwifery Regulators as a key element of midwifery care. So it's enshrined in our organizations at a national level continuity is explicitly part of our model and our philosophy of care in Canada. And so I'm going to talk now specifically about some of the lessons that we've learned in Ontario. Ontario is right in the middle. That's the dark province there. This slide shows the numbers of midwives that we have in each of the provinces and the percentage of the births that we have. And it's very small compared to Indonesia. So in the province where I live in Ontario, each year we have about 140,000 births. So you have more midwives in Indonesia than we have births in the province where I live. But nationally, overall in Canada, midwives now attend about 13% of the births, but we attend more in Ontario. Ontario was the first province where midwives started to be reintroduced into the system. So maybe just a little bit of other background about Canada. The Indigenous peoples of Canada have always had a tradition of midwifery. So we've had midwifery in Canada for thousands of years, but when colonizers came, they oppressed that tradition. So we went for much time in the 1900s where there really was not much midwifery happening. And then both in Indigenous communities and in other communities, people started to ask for midwifery care again. And some of the first midwives to work and to bring midwifery back in Canada were the Inuit Indigenous people of what we call Northern Quebec. And they worked to set up birth centers to be able to keep women in communities there and for them to be able to provide care. And they work in a model where they provide continuity. They know all the women who give birth in the birth center. And then in the 1990s, we had the first province in Ontario where we started to include midwifery in our healthcare system. We started very small. So when we first started, we just had 70 midwives working in Ontario. And midwives now care for roughly about 20% of the births. So 1 in 5 people who is pregnant has a midwife looking after them in Ontario. And there's very high demand for midwifery. So people who are giving birth want to have midwives. We can't look after everybody who wants to have a midwife because we don't have enough midwives. But still, there's a lot of people who don't really understand midwifery. A lot of people who are giving birth don't really know all the training that midwives have and all the expertise. And even there are some healthcare providers, even doctors who don't fully understand what we do as midwives and all the knowledge and skills that we have. And we do have very good outcomes. So the outcomes in Ontario are similar to what is described in the Cochrane Review. People who give birth with a midwife are very satisfied. They have less interventions and good clinical outcomes. One of the things that's been important in supporting continuity of care in Ontario is the way that midwives are funded and paid. And the way that midwives are paid was set up to support continuity of care. So midwives in Ontario are primarily self-employed. They're paid by the Ministry of Health, but it's like they're working in private practice. They work in groups, so they have community-based midwifery practice groups. The funding, the money that comes from the Ministry of Health goes through the practice group, and then it pays the midwives for the work that they do. But the way that we get paid is based on a bundle of care that's basically full continuity of care. So we just get paid once at the very end of looking after somebody. And to get paid for looking after someone, we have to provide care in their pregnancy, during their labor and birth, and in the postpartum. So we do all of that care, and then we get one fee for each person that we look after. And we also provide care to the newborn up until 6 weeks. So the funding has been important to encourage midwives to work in this way. It was set up intentionally to make midwives provide continuity of care, which midwives also wanted to do. Another thing that's been important to support continuity of care is how we are regulated. So I think we're a self-regulated profession in Canada. We're regulated by what we call the College of Midwives. So it's the College of Midwives of Ontario in the province where I work. In some other places, this might be referred to as a council, like the Midwifery Council, and it's what helps to make sure that midwives are practicing safely, and their goal or their responsibility is to protect the public. But they also included in their regulations a requirement for midwives to provide continuity of care. So that was set up right from the very beginning. And there have been some changes recently, but until just a few years ago, our regulations from the College of Midwives specifically said we had to provide continuity, defined as continuity of midwifery care is achieved when a relationship develops over time between a client and a small group of no more than 4 midwives. So we had to either have just 1 midwife or a small team, 2, 3, or 4 midwives to provide care. And this regulation has also really shaped the way in which midwives work in Ontario, and has been important for us to also be able to say, this is how we have to do things. This is the way that we need to provide care. I provided on the bottom a link to the updated standards. They've changed the wording a little bit, but it still supports continuity of care. And one of the things that is important to note here is that we don't have very good research evidence to tell us how big does a team need to be for us to provide continuity, or how small does a team need to be. Some of the evidence suggests maybe you can even have bigger teams and still have continuity. We think that probably based on our experience, we think it's often better for women if we have a smaller team, like of 4 or less. Sometimes things happen though, and it's difficult for it to be such a small team. Maybe midwives get sick and can't keep working, and so you need to have other people who join the team and provide care. But I think that there probably is a difference if you have a team of 20 versus a team of 4. And one of the reasons is that if we have 20 midwives looking after each person, some of them will never meet them before they have their birth, and it doesn't allow as much time to develop a relationship. So we probably need more research in this area, but we do think that probably having a slightly smaller team probably makes a difference in terms of really being able to have relational continuity and good informational continuity. So again, in terms of our regulations, our College of Midwives, the council or the regulator, requires that a midwife has to be available all the time. For anybody who is having care from the midwife needs to be able to reach a midwife 7 days a week, 24 hours each day. And that has to happen all the way through their pregnancy and their postpartum up until their baby is 6 weeks old. And they also recommend that we have 1 midwife who is named as being the coordinating midwife. So we identify who's the most responsible midwife, and that goes back to helping again with what I talked about earlier, to make us feel responsible and to ensure that we coordinate care. And that coordination of care is part of what helps to contribute to the good outcomes. So our model, as you can see, it's very similar to some of the other countries that I talked about. It's similar to what is sometimes called caseload midwifery, or it's similar to the lead maternity care style from New Zealand. And we have a whole bunch of different ways in which, many different ways in which midwives organize their time. So there isn't just one way to work as a team. And I'll talk a little bit more about that on the next slide. So one of the ways in which people sometimes organize their care is what we call primary call. And then other midwives work in what they call shared call. So with primary call, we usually have 1 midwife who's the coordinating midwife who sees the woman for most of their visits. And so they'll have most of their visits with that midwife, and that midwife will usually be available and working most of the time. So in every month, maybe they might take 1 or 2 weekends off, and then the rest of the time they would be available for their clients. They would usually have other midwives who can provide them with backup when they take their time off, but they're on call most of the time. And then the other models that we have, we usually talk about as being shared care models or shared call models. And in those models, the midwives aren't on call as much. So if I was in a team of 2, I would maybe be on call half the time and the other midwife would be on call half the time. And that allows people a little to organize their time differently. The one thing with the less time you're on call, the busier you are when you're on call. So that's sort of the trade-off that happens. And we have a big range in Ontario of how large our practices are, our practice groups. We don't have very many midwives anymore who work with just one. But we do have some small practice groups where there maybe are just 2 or 3 midwives. And then we have in some of our cities very large practice groups, so maybe about 20 midwives who all work in the same practice group. But to support continuity of care, the large practice groups organize in smaller teams. So they have smaller teams that are maybe 3 or 4 midwives often. And so if you have 20 midwives, maybe you have 5 teams of 4 midwives. So one of the most common ways that midwives work is doing 1 week of being on call and 1 week of not being on call. And a lot of the time when they organize that way, the midwife who is on call goes to all the births, and they also do all of the urgent things that happen. So if somebody needs an unplanned visit, or after they have their baby in the first few days when we go and visit them at home, the midwife who is on call would do all of those visits. And the other midwife would do clinic. And so they would do all the scheduled visits for the prenatal visits where somebody's going to come into the clinic for their visits. But there's lots of other ways of doing it as well. I know some midwives where they work in a team of 4, and each midwife does 1 day in the week, so Monday or Tuesday or Wednesday or Thursday, and then they take turns and each midwife does 1 weekend. So there's lots of different ways to organize, and I think the flexibility that happens from midwives working essentially in private practice, being self-employed, allows them to figure out what works best for them and their group. The other thing that I think is very, very important in terms of how we support continuity of care and keeping it part of the way midwives work is that all of our students learn in a continuity of care model. So when our students are doing their learning, most of their placements are working with midwives in group practices, and they spend a lot of time in one placement. So in our program, students currently have 4 terms where they go and work with midwives, and they're in the practice for 12 to 16 weeks at a time. In their first year, they're there for 16 weeks, and they work with 1 or 2 or 3 midwives, and they have continuity with all of the clients that they're seeing. So everybody, when they go to their births, it's people that they've met to do prenatal clinic with. And that helps them to learn how to provide continuity of care midwifery. And in their final year, they have 3 terms in a row where they are in the same practice. So when they start in May and they finish in the month of March, 10 months later. Sometimes at the end, they have people where they did their very first visit and they've done all of their care through their whole pregnancy. And so that helps students to understand the benefits of continuity of care as well. So what are the challenges? Sometimes providing continuity of care can be hard work too, and so it's important that we make sure that we take care of the midwife and figure out ways of delivering continuity of care that work for everybody. So one of the biggest challenges that we've found in Canada is work-life balance. And we know that if we're going to be working and on call for births are unpredictable. They can happen whenever, and so our hours can be irregular. Sometimes people find it hard to balance being on call with the responsibilities of their families. And sometimes it can involve long hours. Sometimes a birth goes for a long time. And so we need to figure out ways to still be able to provide continuity, but also take care of the midwives when that happens. And sometimes we can have multiple clients who are having their baby at the same time, you know, even though maybe you're the named midwife for 2 people, but they have their babies on the same day. And so how do we still provide good care in those situations. Some of the things that I think can help with this are, it is possible for us to organize our time more specifically in shifts if that works for people. If people need to have more predictability because they have young children or other responsibilities, they can organize their time so they maybe have some days in the week when they're on call and other days where they know they're not, and they can always be responsible, and it makes it easier to organize backup or other people to do the things that you're responsible for outside of work when it's less time to organize that. Another thing that can be helpful is having, if everybody is giving birth in the same setting. So in Canada, one of our challenges is we offer a choice of birthplace. So sometimes we might have one person who's giving birth at home and another person who's in the hospital, and that means we have to have people in more places. But if you're just working in one location, so if you're a midwife and you have your own private practice and all your births are going to happen in your private practice, then it makes it a little easier. You don't have to be worrying about being in different places. So a little bit more of what we've learned in Ontario. We know that one of the biggest reasons why people sometimes stop being a midwife and leave the profession is this difficulty balancing their work lives. And from the international research about midwifery and ensuring the sustainability of midwifery, we know that having some flexibility and having different options for how midwives work is very important. And so making sure that there are other ways for midwives to work if we implement continuity of care models is important, so that maybe not everybody is going to provide continuity of care, even though most midwives will provide continuity of care. But the other thing that we know internationally is one of the reasons why it can be hard to work as a midwife is if you don't have autonomy. And having midwifery-led continuity of care models supports midwives to be autonomous, and that's probably one of the most important things about working in these models is that if we support midwives to be autonomous, they're going to find more satisfaction in their work, but they can also make a bigger difference because they can use all of their knowledge and skills in a way to support good outcomes. So what we've seen internationally is that continuity of care models can support preventing burnout and improving midwives' well-being, as well as all the benefits that they have for clients or patients. So these are just some of the lessons again. Being flexible about how you organize your on-call schedules, so figure out what's right for your team. Having options for midwives to still work in other models. Maybe a small number of midwives still might work shifts. They might be working at the hospital. Another challenge that we've had is if you have a small group, if you have a midwifery practice or private practice and you only have 3 or 4 midwives, if one midwife gets sick and it's hard to find somebody else to come, then that increases the workload for everybody. So having support and having midwives who are available to come if you have a shortage can be very helpful. Somebody to provide relief when you have people who are sick. Or one of the other benefits about having your own space that's midwifery-led, I think, is that it also supports autonomy of midwives. So if you can support more births in midwifery private practices, that's a space that belongs to the midwife, and it gives you a little bit more autonomy to provide care in the ways that you know work best, and maybe not to be as restricted by policies that might be created by physicians. And then finally, one of the other things that we've started in Canada, we have our first alongside midwifery unit was just created 5 years ago now. And one of the things that we've found there is we've had the midwife who works in the hospital as a staff person, who we call a hospitalist, can be really important in supporting other midwives to provide continuity of care. So in that model, what happens is at the alongside midwifery unit, we have one midwife who is always there. They're there all the time. And when the midwife from the community comes in with her, the person in labor, Sometimes they can get mentoring and support from that midwife who's at the hospital. So if they're a newer midwife, it's somebody experienced who can help them. But the other thing is that we also the midwife who's in the alongside midwifery unit as the hospitalist can sometimes provide care in early labor before the community midwife comes in. And so by looking after some of the care at the beginning of labor, it means that the community midwife doesn't get as tired, and then they're not too tired to be at the birth. So it actually has been able to help them to ensure that if you have a long labor, that the midwife who's the known midwife can be the one to still be there at the birth. So I'm almost finished talking. I just wanted to talk about one last thing. So this is just a little bit of some of the things that we learned as we from the research we did to evaluate the alongside midwifery unit. And I think one of the main lessons that I would just say from that is that if you want to implement something new, so if you don't have continuity of care and you want to introduce a big change, like everybody's going to switch to providing continuity of care, it's useful to look at the research and the theory about implementation and to use some of those best practices, particularly around what we know about how to do effective change management and also how to transform systems. So the research that we have about change management and system transformation can be really helpful to help us to do a good job when we want to introduce a big change. When we did this research, we used a couple of resources that were quite helpful. So the Consolidated Framework for Implementation Research has taken a lot of research that's been done about implementation, particularly in healthcare, and summarized it. So it gives you a framework for all the things that you might consider when you're thinking about implementing something. And when we looked at what had happened in our situation at the Alongside Midwifery Unit, we also found that this other reference by Tricia Greenall about the diffusion of innovations was useful for us to understand why did this work so well, because it was a big success. And I'll just share some of the lessons that come from what we found at the first Alongside Midwifery Unit. So these are some of the things that they did that helped to make it very successful. First of all, they helped to create a receptive context by building capacity and among the people who worked there to absorb new knowledge and to support a climate of learning. So before they even started, they had a climate where it was safe for people to learn. So people wanted to learn, they wanted to do new things, and if something went wrong, they saw that as an opportunity to learn and to do things better, instead of it being a climate where people were punished or shamed if things went wrong. So that was a good basis for starting to do something new. At the beginning, the other thing they did was they identified all of the key stakeholders, and they worked together with people to figure out what were their common goals? What did they want to work on together? And they had a big meeting at the beginning where they invited women who were giving birth at their hospital. They invited, the midwives were leading this, but they invited the women, they invited all the other healthcare providers, the doctors, the nurses, obstetricians, pediatricians, neonatologists, and anesthesiologists. Everybody who they might work with came to those meetings and had a chance to see what they were thinking about doing and to talk about what their concerns were, but also to talk about their common goals. And they all wanted to provide good, safe care for families and for the people giving birth and for their babies. And so that common goal was useful in reminding them when they had differences of opinion that they all still wanted the same thing. And so it helped them to work through those differences of opinion. The other thing that the hospital did that was really important was they specifically invested in developing leadership skills in the midwives. And so the hospital had one of the first midwives to be working in a management position in a hospital in Ontario. And they supported that midwife to learn new leadership skills. She learned about change management. She learned about system transformation, and then she could use that to lead the project. So that's another thing, like if there's ways to invest in midwifery leadership skills, then I think having strong midwifery leaders can be really helpful for implementing changes. And then they engaged all the stakeholders in the planning process. And when somebody said, I don't like this because I don't think this is going to work, they asked more questions. And rather than trying to just say, no, it'll be fine, they really listened to people, and they, together with them, came up with solutions. Another thing that they did too, that I think I might not have even had on the slides, is they also were able to think about, why would this change be good for everybody? So they listened to people about what the problems were with how things currently worked, and then they thought about, how can we make the solution something that will improve problems for other people? So when they created the Alongside Midwifery Unit, they were solving problems for the obstetricians, and they were solving problems for the clients, and they were solving problems for all the different care providers. And so people felt like the new thing that was going to happen would be better for them, not just better for other people. And this is my last slide. So the last set of things that we learned about was that it was useful for them to really pay attention to communicating well. And they did a lot of work to make sure they kept everybody updated with the project. They had a newsletter. They sent it out every month to let people know, this is what we're doing, this is where we're at. They invited people to ask questions and to let them know what their concerns were. And by having that open, frequent communication, it kept people interested in the project. It also made them feel like they had a voice in the project, and it kept it in their minds. So they didn't forget about it, and when it was actually time to start, they all knew that it was going to start. Another thing that they did was the hospital invested resources and people to actually be able to support the project. So they had a project manager who was dedicated to supporting this project. And that's important because midwives are busy, and midwives are doing lots of other things and already have other jobs. And so having other support to implement the change was really beneficial and helped to make it easier. And also it allowed them to benefit from other kinds of expertise. We have lots of expertise as midwives, and many midwives have good leadership skills, but other people can bring things that can help us to make something happen, and their expertise can help us to do it in a more efficient or effective way. And then the last two things were they made sure that they provided orientation and training for all of the members of the team. So before they opened the Alongside Midwifery Unit, they had many weeks where they did lots of drills and simulation, and they brought people in to show them how things were going to work. So they'd worked through everything in advance, and people felt like they knew what was going to happen. So if you're going to have a system where you change the way people are doing things, if you can make sure that everybody has lots of orientation to that ahead of time, you're likely to catch some of the potential problems ahead of time, but also it means that when things get started, people understand how things will be different. They know what they need to do that's different than how they did them before. And then finally, as they were implementing, they provided regular feedback on how the implementation process was going. So if you have a new project and you implement continuity of care in a setting, letting everybody know how well it's going is helpful and can, again, keep their support for the project. So they did things like they would look at their statistics each month, and they would share with everybody, this was our cesarean section rate. We had a 4% cesarean section rate, and then everybody was like, wow, that's great, and it helped to keep support for the project that they were doing. And that's it. So I'm really looking forward to hearing from you, and I welcome any questions that you have.
Thank you, Dr. Elizabeth, for sharing the informative and interesting topic to us. And now I would like to invite Mrs. Disa to come up to the stage. Maybe you want to give a short explanation related to what our speaker already talked to us in Bahasa Indonesia. So to Mrs. Tisa, please come to the stage.
Try to help them a little bit. Iya, baik, terima kasih. Cukup surprising ya. Tapi ya kurang lebih tadi yang disampaikan, cuman checking the PowerPoint. Yes. Okay, that's it. Yep, from this side. Ya, jadi ada beberapa hal mungkin ya yang bisa kita ambil dari materi ini, bahwa sebetulnya untuk continuity of care itu tadi sudah dijelaskan juga beberapa ya secara prinsip teorinya bagaimana, bahwa satu pasien itu betul-betul look after oleh bidan yang dia kenal, yang walaupun nanti pada implementasinya bisa dilakukan secara berkelompok, tapi dipastikan bahwa nanti akan ada keberlanjutan ya, dan keberlanjutan itu ada beberapa aspek seperti yang beliau sampaikan tadi, termasuk bagaimana informasi, kemudian bagaimana memanagenya, sampai dengan membangun hubungan. Karena sebetulnya kan prinsipnya kita harus membangun partnership ya, throughout the process, mulai dari kehamilan, persalinan sampai dengan dini fase. Sementara di kita kan biasanya informasi dilakukan melalui apa? Hanya melalui buku KIA saja yang warna pink, ya kan? But not necessarily, misalnya saya pergi ke bidan A, bidan B misalnya, itu kan tidak selalu menjamin saya akan bertemu bidan yang sama. Nah sementara di COC itu tidak demikian. Dia harus bertemu bidan yang sama yang sudah disepakati. Either itu satu orang tapi maksimal 4 tadi ya yang dia sebutkan. Itu implementasinya di Kanada. Yang nanti mungkin akan bisa kita pertimbangkan di sini nanti bagaimana misalnya mau diimplementasikan. Sehingga bagaimana informasi, bagaimana kalaupun memang dia membutuhkan sesuatu itu betul-betul spesifik dan bisa diikuti, dan bagaimana hubungan itu juga akan sangat mungkin terbentuk sepanjang prosesnya. Kemudian, excuse me, next slide, I think. Dan ya itu secara prinsip ya, yang saya yakin mungkin untuk materi-materi yang lain teman-teman dan ibu-ibu sekalian juga sudah pernah baca, nanti bisa merefer penelitiannya Prof. Jane Sendal, systematic review, karena itu yang menjadi rujukan hampir ya di seluruh dunia ya, karena systematic review kita tahu dia di hierarchy of evidence dia paling tinggi dan jadi rujukan banyak negara ya, termasuk yang tadi beliau sampaikan juga membuktikan ya bagaimana keuntungan ya, seperti apa modelnya, kemudian secara detail ya, mulai lebih jarang dia akan mendapatkan intervensi dan seterusnya. Itu nanti teman-teman mungkin bisa akses ya untuk penelitian Prof. Jan Sendal yang saya yakin semuanya pasti pernah baca. Nah untuk implementasinya di Kanada, karena tadi mungkin ada yang menangkap di Kanada itu berbeda dengan kita, bedanya apa tadi? Justru pelayanan midwifery di sana itu hanya bisa diakses oleh orang-orang yang punya duit banyak. Berbeda dengan kita ya. Justru mereka itu tidak semua bisa mengakses pelayanan kebidanan karena di sana itu ya dilihat sebagai pelayanan yang eksklusif begitu ya. Dan itu berbeda ya dengan di kita, justru kan kebalikannya, kita biasanya low income people lah, kalau nggak punya duit perginya ke bidan, kalau punya duit perginya ke dokter. Nah itu mungkin berbeda dengan mereka. Dan karena mungkin selain bidannya juga tidak banyak, artinya pasien juga tidak terlalu banyak, sehingga mereka pun juga menerapkan continuity of care itu betul-betul ideal ya, karena mereka pun juga kan harus membayar ya untuk mengaksesnya. Jadi sama kurang lebih dengan teori yang tadi sudah disampaikan, dan di sana memang 20% ya dari total semua persalinan itu dibantu oleh bidan begitu, yang dari hasil COC ya. Jadi bukan tiba-tiba ujuk-ujuk gitu ya, ujuk-ujuk itu apa ya bahasa Jawanya? Ya out of the blue ya, dia tahu-tahu datang. Kalau di kita kan biasanya kayak ya udah nanti saya mau bersalin di rumah mertua saya gitu, di rumah eyang saya, di rumah apa. Nah itu ya mungkin doesn't work that way kalau di sana. Kemudian ya sudah terbukti ya bagaimana apa namanya kepuasan ya, kemudian excellency baik dilihat dari fisik maupun psikis ya, termasuk bagaimana dia bisa merasa puas dengan pelayanannya, itu pun sudah terbukti ya di sana, dan kebutuhannya itu sebetulnya tinggi. Tapi ya justru karena kebutuhannya tinggi di sana itu mereka akhirnya beberapa bidan itu memang kemudian berpikir ya ini ada cara lain nggak sih selain bekerja dengan model COC ini, karena di sana memang tidak umum bidan itu bekerja di rumah sakit. Makanya tadi dia di PowerPoint-nya tadi ya untuk balancing ya mereka memikirkan beberapa sektor, beberapa bukan sektor ya, setting yang mungkin nanti bisa dimasuki oleh bidan juga begitu ya, karena mereka saking intensnya ya, karena memberikan providing care itu betul-betul komprehensif, sehingga beberapa diantaranya memang merasa workload ya, load pekerjaannya itu luar biasa begitu. Ya, kemudian ya di sana self employed memang. Jadi kalau di kita kan bisa milih ya, membayar privately gitu kan, membayar oleh pasien sendiri atau lewat health coverage ya, lewat asuransi ya, lewat BPJS ya. Nah, sementara di sana itu semuanya dibayar melalui pemerintah begitu ya. Walaupun bekerjanya itu ya di luar bukan di luar sistem. Jadi mereka ya memiliki praktik yang pada umumnya ya memang jarang ya dimiliki oleh satu orang, mereka berkelompok begitu. Jadi dalam komunitas mereka punya kelompok midwife walaupun tidak banyak begitu ya, tapi terdaftar dan itu semua dibayar oleh pemerintah melalui Kementerian Kesehatan. Jadi semuanya di cover ya, semua di cover oleh pemerintah. Artinya di sini bahwa midwife itu diakui ya di sana gitu. Jadi bukan kayak mahal karena mereka membayar sendiri, bukan, tapi karena memang diakui oleh pemerintahnya, which is good. Di kita kan mungkin belum begitu. Kemudian ya ini funded through community based juga dan paid by course of care. Jadi kita hanya akan dibayar di sana kalau itu sudah sampai selesai. Karena tadi disampaikannya sampai 6 minggu ya, 6 minggu postpartum. Jadi setelah 6 minggu postpartum, sejak kehamilan sampai 6 minggu postpartum uang tuh baru keluar. Jadi tidak ya udah nanti jasa persalinan sendiri, jasa ini KB sendiri, apa sendiri mesti seperti di kita ya. Tapi by course. Jadi satu kasus tuh akan dibayarkan sampai dia selesai continuity-nya. Jadi untuk memastikan bahwa dia memang betul-betul continuity. Next please. Kemudian mereka juga diperkuat dengan konsil ya, dan konsilnya coba kita lihat ada beberapa negara, misalnya Australia itu konsilnya gabung ya, konsil antara nurse dan midwife gabung. Kemudian di UK juga nurse dan midwife gabung, sementara di Kanada ini konsilnya separated, jadi completely terpisah, mereka punya konsil sendiri, konsil kebidanan, makanya kuat sekali memang mereka di sana. Kemudian ya nanti mereka membantu meregulasi seperti apa secara teknis implementasinya di lapangan. Kemudian ini pun sehingga mereka juga dalam secara praktikal ya, mereka membuat detail-detail begitu. Kira-kira seperti apa bagaimana bagaimana mengimplementasikan ya secara teknis di lapangan sesuai dengan konteks mereka. Ini juga bisa dilihat dokumennya, freely access. Kemudian ya ini sampai 6 minggu. Kemudian biasanya walaupun di maksimal 4 orang kan ya, kalaupun memang dalam grup pasti akan ada satu siapa leadernya. Kenapa harus dalam grup? In case misalnya saya sakit, saya apa gitu ya, yang jadi koordinatornya nanti bisa di take over oleh yang menjadi kelompoknya begitu. Dan di kita memang mungkin ya bisa jadi mirip tapi berbeda sebetulnya. Kenapa berbeda? Karena walaupun dia periksa di satu PMB yang sama, apakah menjamin dia akan bertemu bidan yang sama? Tidak kan ya. Dan itu pun tidak disepakati sejak awal. Nanti oleh siapa yang akan look after ibu gitu kan pada saat periksa, dan itu yang tidak terjadi di kita. Jadi tidak ada concern ya di awal. Sementara continuity of care itu butuh concern, dan siapa yang saya mau dirawat oleh bidan siapa, dan bidannya pun juga harus bersedia. Beliau memang bersedia merawat siapa. Nah, di kita kan ya tergantung pasien yang datang, tergantung bidan siapa yang praktik begitu. Kemudian ya ini di beberapa tempat memang bisa disebut caseload, bisa disebut lead maternity care kalau di New Zealand ya. Kemudian Ontario juga ini. Jadi kalau dalam kelompok ya mereka dalam implementasinya ya COC ini mereka harus siap 24 jam ya, 24/7 kan kata dia tadi. Ya kalaupun dibutuhkan kapanpun ya dia harus siap. Intinya begitu. Oke. Next. Kemudian ya ini di model COC-nya ya memang ada beberapa variasi dalam implementasinya, itu sebetulnya modifikasi dalam pemberian asuhannya saja. Hanya saja memang ini ya, nanti kalaupun memang ada misalnya kapan liburnya, kapan nggak bisa nanti kalau periksa. Jadi itu nanti akan sangat fleksibel tergantung bagaimana kita menyepakati bersama pasien begitu ya. Sementara kalau di kita kan pasti pasien akan lihat tempat praktiknya ya. Kalau libur ya udah libur gitu, kecuali mungkin ada hal-hal yang sifatnya emergensi. Nah ini ya termasuk kapan mereka mau liburan dan seterusnya, itu biasanya akan disepakati di sana. Oke. Kemudian ya memang di community seperti yang tadi beliau sampaikan itu, mereka itu kan ada satu grup ya, kelompok bidan begitu, biasanya terdiri dari 20 tadi. Tapi bukan 20-20-nya untuk mengasuh satu orang ya, bukan. Pada umumnya satu orang diasuh oleh 1 sampai 4. Tapi ya ini ya shared care. Jadi shared care-nya itu berbeda dengan kita. Sementara di kita kan shared care kita itu kalau dia pergi ke bidan, maka yang bertanggung jawab bidan. Kalau dia pergi ke objin, yang bertanggung jawab objin. Kalau dia pergi ke puskesmas, yang bertanggung jawab kan puskesmas, entah siapa yang memberikan pelayanan. Kalau dia pergi ke rumah sakit, ya terserah nanti rumah sakit yang akan bertanggung jawab. Tapi kan ini tidak berkaitan. Kecuali nunggu apa kalau di kita? Nunggu emergensi ya, nunggu ada audit baru dilihat apakah mereka berhubungan atau tidak, dan yang menghubungkan kan hanya buku pink. Sementara di mereka tidak, walaupun shared care yang terdiri dari 4 orang tadi, tapi mereka betul-betul berkomunikasi gitu ya, berkomunikasi intens. Jadi tidak hanya pasien yang bawa bukunya begitu, tapi tadi ya makanya dia bilang ada prinsipnya kan, termasuk informasi, manajemen, sampai dengan yang ketiga. Itu betul-betul partnership ya, relationship. Itu terjalin walaupun mereka diasuh oleh satu grup begitu ya, satu kelompok. Kemudian ya ini praktiknya aja bisa jadi nanti ada yang libur, ada yang siap on call begitu ya. Kemudian ya ini ya kalaupun nanti 3 sampai 4 midwives, teman-teman pasti sudah bisa melihat semua. Kemudian mahasiswa juga wajib untuk bisa melakukan praktik untuk punya pasien untuk COC. Ada beberapa pasien yang appointed menjadi pasien students itu begitu ya untuk COC-nya. Nah ini ya, ini challenge untuk mereka. Walaupun karena kita kan memang belum COC-nya belum seideal itu begitu. Jadi mungkin kita juga ya kalau kita kan shiftnya 8 jam kan, jelas gitu. Kalau udah praktik di baik itu PMB atau mana kan pada umumnya 8 jam. Karena mereka on call ya. Jadi kadang itu they find it hard. Jadi mungkin membagi waktu ya bersama keluarga dan seperti apa karir begitu, sehingga dia ya dan kan mungkin saja nanti pada saat yang bersamaan ada pasien yang manggil di sana, manggil juga begitu. Nah itu challenging ya, itu memang tantangan begitu yang mereka rasakan. Kemudian next. Jadi ini, nah sehingga mereka pun melihat ya di Ontario itu, karena ya di sana kan memang betul-betul continuity of care aja ya bentuk pelayanannya itu, bentuk asuhan yang diberikannya. Sementara mungkin di international konteks termasuk di kita itu kan fleksibel ya kerjanya. Tapi ya begitu, ada asuhan yang memang kita pertaruhkan begitu ya, akhirnya ya asuhannya memang tidak optimal. Nah mereka sedang menimbang nih bagaimana untuk mixing begitu ya. Apakah ada opsi lain yang nanti akan bisa membantu balancing workload-nya? Ya, baik. I think that's it. Ya, jadi ini mungkin potensial solution, nanti teman-teman bisa lihat sendiri. Kurang lebih seperti itu COC di Kanada. Terima kasih.
Thank you, Mrs. Tisa, for the brief explanations. Ladies and gentlemen, now we would like to proceed to the discussion session. So for the participant who want to deliver the questions, we will open 3 questions in these sections. Please raise your hand. If you want to deliver the question in Bahasa, it is okay. I will help you to translate it to English. And also for the participant in the Zoom meeting, if you have any question, please type the question in the chat box and I will read it to the speaker. Thank you. So for the audience in this hall, is there anyone who wants to deliver the questions? Please raise your hand. Okay, we have 3 students. Okay, to Davina. Davina? Yeah, could you please come forward? Okay, please come forward.
Okay, good morning, Dr. Elizabeth. My name is Davina. I'm a student of Midwifery Bachelor Study Program of Institute of Technology and Health of Bali. And I want to ask you about your material. As you explained before, there is a lot of challenges in Canada. And as a midwifery student, I think in Indonesia we has a similar challenges. I think is work-life balance and overload work. And my question is, how we can get a work-life balance in Indonesia, when in Indonesia, I think, there is a lot of people don't want to be a midwife because they think our profession is not important and they just want to obstetrician. I think that's all my question. I hope you can give me a suggestion. Thank you.
Thank you very much for your question. Yes, I think that is something, maybe we share that a little bit around the globe, I think, as midwives. Often our profession doesn't quite get the respect that it deserves, and so sometimes it's difficult to convince people that being a midwife is an important thing. When we think about work-life balance, I think it's something where we need to think about it in lots of different levels. So one thing that I think is useful is at the level of a student, learning about resilience and ways in which we can be able to cope with the challenges of being a midwife when we're students. So that's a responsibility for those of us who are midwifery educators. It's important for us to make sure that we include that in what we're teaching so that you have ways to learn about that when you're still a student. I think another piece that's important is for our midwifery associations. So our midwifery associations are really important advocates for the profession, and they're the link with government. And so having a strong midwifery association and supporting that association and having the association do work to ensure that midwives have good working conditions, that they're paid adequately, that they are going to be able to have time away from work to support the conditions that will help support good work-life balance is really important. And then I think the final piece, I don't think we've figured out how to do this, is trying to figure out how do we change that respect for midwives? How do we make people in the public understand what we do and respect all the expertise that midwives have? How do we get that respect from other health professions and from the public in general? And I think that's a difficult problem for us to solve. I think it's going to be something where we need to work in many different ways to do that. I think as midwives, we can take on to try and maybe use social media in a smart way and try and sell the benefits of the amazing work that midwives do and talking about our successes. And maybe also getting the women that we care for who really love what we do to share about it as well, maybe on social media. From some of the research that we've done in Canada, we were trying to figure out, like, why don't people know about midwives? Why do we have some people who don't use midwifery care? And we learned a couple of important things. One important thing was the people who want midwifery care usually want it because one of their friends or their family had midwifery care and told them, midwives are amazing, you have to have midwifery care, they do such a good job. And so if we can figure out how to use that to try and increase people's awareness of midwifery, that might be helpful. Our Midwifery Association in Ontario has created videos of women who've had midwifery care telling their stories and sharing them. So using like social media so that clients are the women that we care for, their voices can help to explain why midwives are important and why the work that we do is so valuable. And then I think there are lots of other ways too that we might address it, but I think interprofessional education is probably very important. We need to build respect from other healthcare providers while they're still students. So working with the other students who are here at your university so that they understand your profession and what you do is important to contribute to that. And we probably need we need support to be able to also share that message with other healthcare providers who are already working. And that might be, again, maybe midwifery associations. I think we need to try and address it in many ways. So hopefully that helps a little bit.
Thank you, Dr. Elizabeth, for the wonderful answer. And okay, for Davina, is that clear for you? Okay, we have another questions from the students as well. So to Sinta. Sinta? Yes, please come forward.
Good morning, Miss Elizabeth. I'm sorry about my English is not good, but I'm trying it's my best. Okay. Thank you for the opportunity. Let me introduce to myself. My name is Nilo Putu Sinta Wulandari. Permission to ask reading to material provide. What needs to be considered in providing continuity of care? And what are the inhibiting factors for continuing midwifery care? Thank you.
Thank you very much. That's a big question, but thank you. And I apologize, I don't speak Bahasa, so all of you are doing a better job than me being able to speak some English. I think in terms of what we need to consider, continuity of care is going to look a little bit different depending on where you are and what your context is. But I think if you're wanting to implement continuity of care where you are, the last few slides that I was talking about, things to consider when we implement, I think would be the places where I would start. So if you want to implement continuity of care, you need to have an environment where the other people around you also want to implement continuity of care. So starting to find other people who share that dream and who also want to have continuity of care is important, so you can start to work together. And you need to work with other people, not just midwives. So it's important to be able to explain why it's a good thing, talk about the research evidence, and convince the physicians where you work as well. Maybe also be advocating at a higher level, midwifery associations advocating to the government about why it's important to support midwives to provide continuity of care. And then in terms of some of the challenges, I think the biggest challenge is just, change can be difficult. So if we work in one way, all of our systems are set up to support that way of working. And if you want to change things, it's going to change it's going to require changes in lots of different areas. So sitting down with the other people who really want to make that change and trying to identify all the different ways where you need to think about how would it affect this? How would it affect this? And answer those questions, and then talk to other people, talk to the people who would be involved, so that you can get more people to understand the benefits of the change that you want to make, and so that you can also try and identify and solve the challenges and the problems before you actually implement the change. Yeah.
Thank you, Dr. Elizabeth. About Sinta, is that clear for you? Okay, thank you. Now I will open the last questions to Dea. Please come forward.
For the first time, thank you, Dr. Elizabeth, for the amazing presentation. My name is Dea. I'm a student from a Bachelor of Midwifery study program. I have one question for you, Dr. Elizabeth. Can you give any strategy or suggestion for us as students, especially in Indonesia, how to get closer to client or patient, how to build the trust between the midwife and clients, so that we can achieve the goal of continuity of care maximally. I think that's all from me. Thank you.
Thank you very much for your question. So that's another really good question. I think there's two pieces to it. So one is to support students to do that, we need our clinical preceptors to support that as well. So it's really important for any of you who are listening, maybe on Zoom, if you're working as a preceptor and teaching students, we have a responsibility when we're a preceptor to help support students to develop a relationship with the women that we're working with as well. So trying to create opportunities for the student to interact with the pregnant woman or the woman in labor to be able to get to build that relationship with people. And then I think as a student, if you want to move closer to continuity and to be able to build that relationship, building good skills in getting to know people and building your communication skills is really important. So being able to listen well and to hear what people are telling you and to ask good questions. So if you hear somebody talking about something and maybe they don't say very much about it, but they mention something that you think maybe that's a concern for them, asking them questions and following up and letting them talk and tell you about who they are and what's important to them. I think that's one of the key skills to help build trust. When people feel like you want to listen to them and you've heard what they've said and you understand what they've said and you support them and you want to support them to have a good experience, all of those things help to build that relationship and the relational continuity with people.
Thank you, Dr. Elizabeth. So is that clear to Dea? Is that clear? Okay, thank you. So, ladies and gentlemen, finally we come to the end of the first session. So, I would like to say thank you very much for Dr. Elizabeth for your interesting and awesome topic that you has been shared to our students and also our lecturer. And now, to close the first sessions, I would like to invite the head of Bachelor Program in Midwifery, Mrs. Dwina, to come up to the stage to hand over certificate to our first speaker. To Ms. Dwina, time is yours. Thank you so much, Mrs. Dwina and Dr. Elizabeth. You may return to your seat, please. Well, ladies and gentlemen, that's all the first session of our guest lecture today. And now for the next agenda is lunch break. So for the attendees are welcome to have lunch break for 1 hour, and the next speaker session will be start after the lunch break at 12 p.m. Thank you.